3 years female with right eye proptosis and mouth deviation. On T2 and flare there are pontine and middle cerebellar peduncles patches of abnormal signal which elicit low signal on T1 and high signal on T2 and flare. On SWI there's a linear vertical DVA eliciting a low signal with a surrounding blush of low signal adjacent to the DVA. On the post-contrast series, there's the enhancement of the DVA, no thrombosis, with surrounding patchy enhancement corresponding to the area of low signal and blooming on SWI, which is likely representing capillary telangiectasia. Adjacent pontine and middle cerebellar peduncle non-enhancing patches of abnormal signal, likely representing edema or gliosis. A DVA is characterized by the caput medusae sign of veins draining into a single larger collecting vein, which in turn drains into either a dural sinus or into a deep ependymal vein. The appearance has also been likened to a palm tree. Developmental venous anomalies are usually incidental findings. However, patients can present with intracranial hemorrhage. 1 to 5% association has also been described with ischemic stroke and epilepsy. Associations. Lesions are usually solitary in 75% except in blue rubber bleb nevus syndrome. 20%, range 8 to 33%, of cases too are associated with cavernous malformations and are referred to as mixed vascular malformations (MVM). Venous malformations of the head and neck. Cortical dysplasia. Differential diagnosis. Generally, the appearances will be typical and no differential should be offered. In some instances, imaging appearances may be atypical or be confounded by concurrent pathology, for example hemorrhage. In such cases it is worth considering. Arteriovenous malformation, dural sinus thrombosis or dural arteriovenous fistula with collateral transparency mal-drainage. Sturge-Weber syndrome with leptomeningeal angiomatosis. Demyelination may also have enlarged medullary veins.